Welcome to the neurosurgical case room. This is our last session before Eid because we have Eid holidays from Tuesday to Thursday, but we are going to catch up on Friday and Saturday, inshallah ta'ala. So let's start with the Falcine Meningiomas. Let's see. So before we move on to the meningiomas themselves, you all know the pattern by this point. We start with all the relevant anatomy, which is important for us from a surgical point of view, because anatomy is your GPS. You cannot proceed for the surgical management or for any sort of management if you're not aware with the relevant anatomy. Strictly speaking, when we talk about falcine meningiomas, they arise from Falx cerebri, and there is a layer of tissue, there's a layer of cortex between them, which comes from the interhemispheric fissure. And why is that important? Because the previous session that we did was the parasagittal meningiomas, and there is a very, very small difference between both of them. Please keep yourself muted. I see. So let's see. This is one hemisphere. This is another hemisphere. And then we have the superior sagittal sinus somewhere here in between. And let me see, we have this Falx here. So these are the dural layers. When we talk about falcine meningiomas and the parasagittal meningiomas, let me draw them here. We did discuss this yesterday. If this is a lesion which looks like this, involving some portion of the Falx, mainly centered over this region, along with involvement of the superior sagittal sinus, then this is a parasagittal meningioma. And this region here, this is the parasagittal angle, which is completely filled by the tumor itself. So the cortex, it ends up getting pushed here, sort of, because meningiomas are extraaxial tumors, right? Whereas when we talk about the, let me change the color so that it's more visible. Okay. When we talk about falcine meningiomas, they are in the same vicinity here as well. And they involve Falx mainly. They could also involve this lower portion of the superior sagittal sinus. You see this purple thing here? This is the lower portion of the superior sagittal sinus. So how do we differentiate? I think somebody asked this in a previous session as well. How would we differentiate? The difference would still be around this parasagittal angle. If this angle is filled, then this is a parasagittal meningioma. If this angle is not filled, and there is this interhemispheric cortex, because this cortex is then going to be pushed towards this side. So if we have this interhemispheric cortex and the parasagittal angle, which is being represented by this green arrow, if that is empty, this means that this is a falcine meningioma. Are we all clear about this?
Yes.
Okay. Let me clear this all. So before we actually move on to the falcine meningiomas, let's look at some of the beautiful anatomy which is relevant to us. You all know the attachments of the Falx cerebri. We have the anterior attachment where it attaches to the crista calli of the ethmoid bone, the frontal crest. Superiorly, it is along the midline inner table of the skull, and the sagittal sulcus contains the superior sagittal sinus. Posteriorly, joins the upper surface of the tentorium cerebelli. I'm going to show you the images so that it's clearer, and it attaches near the internal occipital protuberance, which is the posterior most edge. And it goes like this. Let me draw, even though we have images ahead. So this is how it looks like, sort of. Narrow anteriorly, broader posteriorly. And this here, we have the, draw. This is the internal occipital protuberance around this. And around here, this is the sagittal section, right? Around here, we have this attachment with the tentorium cerebelli. and the tentorium cerebelli is then continued like this. In the axial plane, this is the sagittal plane. The inferior margin is free. This margin that is making up the inferior portion, this is free. It has a sinus, which sinus we are going to discuss, but it is not attached anywhere else. And yes, it has the inferior sagittal sinus. Move. Broadly speaking, the important relations are something we already know. We have the superior sagittal sinus superiorly. We have the parasagittal bridging veins on which we spent a lot of time during the parasagittal meningiomas. And then we have the inner skull table. Inferiorly, we have corpus callosum, we have pericallosal arteries, singular gyri. Laterally, we have both the cerebral hemispheres, specifically the medial surfaces that we have discussed, I believe, in a previous session. Posteriorly, we have the straight sinus at the focotentorial junction. So now let's look at some of the images and start with the illustrations first. Draw. So we have already elucidated this thing that Falx cerebri is narrow anteriorly, it's broader posteriorly. Anteriorly, it attaches here to the crista galli. This is the attachment onto the tentorium cerebelli. I'm sure you're all aware that tentorium cerebelli will run in the axial plane from here. So this will be a 90-degree thing. This is a 90-degree angle here. And it's perfectly perpendicular to each other, more or less, sort of. The junction, which is the focotentorial junction, it contains straight sinus, right? And if we go ahead, right along the inferior, the straight sinus, we have the great vein of Galen, which goes somewhat like this. Let me clear. Goes sort of like this, the inferior vein of Galen. On the superior portion, this is the superior sagittal sinus, and where this is joining the internal occipital protuberance, this region has the torcula or the confluence of sinuses. So Falx is, in itself, it's just a dural structure, a dural partition, which is dual layered. Also, let me mention that there's a dual layer when we talk from a microneurosurgical point of view. So this is made up of dura. We know this is a fold of dura made up of two microsurgical layers. Technically, this is benign. Why is it important? Because it is connected with a lot of important structures. So this is the basic run through. Are we all on the same page?
Yes.
Yes, ma'am.
Moving on. I'm going to show you the easy pictures first. They're all very easy, easy to understand, pleasant to look at. We will come to the cadaveric dissections later on. Let me move. You can see the cristaculi here and the attachment. We have the inferior sagittal sinus running in here. Along with that, you can see the superior sagittal sinus. You can also see the focotentorial edge, the straight sinus, and this is the confluence of sinus here. Interestingly, because they have also cut the tent, this tent was supposed to go like this. It would have been covered. They have taken it away so that we can look at some more of the venous anatomy of the brain. Change the color. What sinus is this? We have discussed it thoroughly in probably 2 or 3 sessions. Which venous sinus is this? Sphenoparietal, that's right. So this is the sphenoparietal sinus, which drains mainly the superficial sylvian vein, right? Or the superficial middle cerebral vein, which is the main drainage of the lateral surface of temporal lobe, the frontal lobe, inferior portion of the frontal lobe. This is the sphenoparietal sinus. Then we have this portion, the cavernous sinuses. When we come slightly posteriorly, there will be 2 projections here. What are those 2 projections? What will be
Posterior clinoid.
That's right, there will be posterior clinoidal process. I'm just reminding you of the anatomy that we have covered so far. These are the anterior clinoidal processes. And this is the dorsum sella. You can see the pituitary stalk here. You can also see the pituitary. You can see the diaphragma sella here. And the basilovenous plexus that is visible. I am going to highlight a sinus, which is this one, this sinus.
Petrosal sinus, superficial petrosal sinus.
The superior petrosal sinus. There are two pairs, right? We have the superior petrosal sinus and then we have the inferior petrosal sinus. This is superior petrosal sinus. Which one is this? Easy to say. It's the other pair.
Inferior petrosal sinus.
That's right. It's the inferior petrosal sinus. If I take this portion of the tent away, I'm going to take a look at it as well. And then posteriorly, it is draining into the, which sinus is this? Here?
Sigmoid sinus.
Sigmoid sinus. It has a very particular shape. And there is a very faint shadow. If you look at it, just going like this, and it's also coming here. Which sinus would this be?
Transverse.
This is the transverse sinus. So the goal is to understand the anatomy in its 3D form so that you can imagine once we change the view. Let's move to the next slide. So the more interesting images start from here. All the anatomy that we discussed in the previous illustration, it is visible in this one. You can see the Falx and its fibers, which are visible beautifully. You can also see the anterior edge, which is attached here to the base of the skull. What is the significance? Where do we, can we tether this? Do we tether this? Do we incise this?
Yes.
Which procedure usually? Anterior skull base tumors, right? Or any procedure that requires us to expose the anterior skull base, we can safely detach the falcine attachment from the crista galli. It's not going to cause much of a problem. Apart from that, you can also take a look at these vessels here. This is the superior sagittal sinus. These small vessels are the bridging veins, the bridging cortical veins. This is the inferior sagittal sinus, which is running in the free edge. And basically, this is the anatomical illustration of the previous easy one. Straight sinus. A vein of Galen has been cut from here. This was the vein of Galen somewhere here. Rest of the anatomy stays the same. But I'm sure you all can appreciate this is the anterior cranial fossa. This portion, let me draw. This portion is the anterior cranial fossa, right? And from here, where we have the sphenoparietal sinus, this is also demarcating. What is this demarcating?
Anterior from temporal middle.
Yes, this is the anterior portion. This is the lesser wing of a sphenoid, along which the this is the sphenoid wing along which the sphenoparietal sinus runs. And then we have the petrous portion here of the temporal bone in which the superior petrosal sinus is running. And you can see the middle cranial fossa here as well. Given that we have covered this anatomy, moving on. This is a cadaveric image from Roton. And now you will start to appreciate the relevant structures. We are going to build on what we are learning. So the superior margin was superior sagittal sinus, right? The inferior margin was inferior sagittal sinus. What was underneath the inferior margin? We have two structures, depending on how anterior or how posterior we are. Can somebody tell me those two structures?
Corpus callosum and cingulate veins.
Your voice is not audible. Can you say that again? Okay, so we have two structures. We have the cingulate gyrus plus we have the corpus callosum, depending on how anterior or how posterior we are. Because we discussed this, that the Falx is shorter anteriorly and broader posteriorly. You can also see how visible this is. Let me draw the margin. You can see that the anterior width is way less than what is available posteriorly. Let me draw this here for your comparison. So what ends up happening is anteriorly some portion of the cingulate gyrus is exposed, which is not the case posteriorly. Once we cross a certain level, once we go posteriorly, the cingulate gyrus will not be visible. Anteriorly, it would be visible. Posteriorly, corpus callosum and especially the splenium will be in direct contact with the margin of the Falx. What does this mean for patients with raised ICP? I'm sure you all know it's just a twisted way of this question. That's right. We have subfalcine herniation, which occurs because Falx is short on the inside. Let me write it here. I'm going to clean it up later on. So subfalcine herniation can occur here in this region with significant impact on the branches of ACA, ACOM, and the cingulate gyrus. And if a patient has significant amount of subfalcine herniation and you delay the surgery, in the cases where the herniation has stayed there for quite a long time, you delay the surgery, what ends up happening is patient might have postoperatively ACA or ACOM territory infarcts because there will be severe compression on this region here. Posteriorly, we have a splenium, and anteriorly, we will have the genu, the rostrum, the body. Apart from that, what other important structures can you see here?
Thalamus.
Oh, yes. What I meant was what other structures that are relevant. So the anterior portion of Falx, it is still far away. It will not be in direct contact. Why is it important? It is important because if we are doing anterior interhemispheric approach, we should know what structures we can encounter. So we can encounter the ACA, the bifurcation of ACA, what is that called? The ACA ACOM complex, and then we can see the A2, A3, A4. Let me clear this. So this entire complex is going to be visible if we are going via the anterior interhemispheric approach. Let's move to the next slide. Now, if you look at it, all the structures that we previously discussed, they are visible here. You can see the ACA and a portion of the ACOM. What artery is this? This is part of ACA, right?
Pericallosal?
Yes, pericallosal is somewhere here. And let's see, this is pericallosal artery that they have marked here. But I think this is also pericallosal. I'm not 100% sure. Let me clean this up. This is marked as callosal artery. I've never heard of that. But this usually is the location of pericallosal artery. The above location, this is the location of the callosomarginal artery. So I'm not sure why this is labeled like this. They have labeled the callosomarginal artery here for some reason. I'm not sure why. Usually pericallosal artery is run right over the corpus callosum. Apart from that, I think we can see a portion that has been cut off here. This is the ACOM. Once we move ahead, this is going to make a terminal portion, the A4 and the A5 segments of ACA. So why is that important? It is important for us if we are going via the interhemispheric approach, which we will need for the Falcine meningiomas. We are going to encounter the terminal branches of ACA, or if the meningioma is slightly anteriorly, we probably will encounter the middle segments of ACA as well, like A3. Clear this. So yes, this is marked properly. I am not sure, maybe there was an anatomic variation or something. This is A2, and you can see the ACOM has been cut here. And then this is the pericallosal artery, which is traveling right around the corpus callosum. This is the A4 segment. If we go slightly posteriorly, the posterior branches would be A5 segment. This is here. This is the callosomarginal artery, which runs around which gyrus? Which is the gyrus?
Cingulate gyrus.
That's right. So this will run around the cingulate gyrus, the callosomarginal artery. Why is that important? Because once we are opening up this space, the callosomarginal artery is usually the first major vessel that we will encounter in this space, and then the cingulate gyrus, and then we need to identify, okay, we are probably very close to the pericallosal arteries and the corpus callosum. Apart from that, in fact, we missed this. On the medial surface, we know this is paracentral lobule. And what is the content of the paracentral lobule? This goes here in between the central sulcus, right? So paracentral lobule is going to contain what?
Motor cortex.
And this would be both.
Speech area.
Here's Dr. Lalitha.
The speech area, the sensory speech.
No. No. Paracentral lobule is the medial portion of the primary motor and sensory cortex, if I'm not wrong.
Okay.
The speech area is in the inferior parietal lobule. We have discussed this, I guess.
Yes. Yeah, I
Yes.
got it wrong.
That is the inferior parietal lobule, which is the speech area. The vernix area, I think you were talking about that. The supramarginal gyrus, the angular gyrus, etc., etc. Paracentral lobule usually contains the primary motor cortex and the primary sensory cortex. Why is that important? Right anterior to the paracentral lobule, there is another area which will be labeled as the supplementary motor cortex. Why is that important? Because if this is affected, then patient will have the supplementary motor area syndrome, which could be akinetic mutism, etc., etc. We have discussed that as well. When we go even more anterior, what do we have here? We probably would have the micturition centers, right? The micturition center would be there, and then, the normal frontal cortex. Why are we concerned? We are concerned because once we are operating, we want to be sure which area are we dealing with. Is it the primary motor cortex? Is it the supplementary motor area? Because the deficit pattern between both is very different. The deficit pattern with supplementary motor area involvement is temporary, it's transient, whereas the deficit pattern with the primary motor cortex is going to be permanent. I am audible, right?
Yes, clear.
Let me know if there's any breakage in the voice or anything.
Okay.
Moving on, this is the same anatomy that we have discussed, the A2, the A3. These are segments. Previously, we were discussing the branches. When do we call it A2?
After ACOM?
Yes, after ACOM. So this is post-communicating segment, right? And when do we call it A3?
After the epigenia.
Yes, and after callosomarginal artery has left the main trunk, right?
Yes.
So we have the A2, we have A3, we have A4, A5, which is the terminal branch. Let's look at a few other images. So this is a posterior view. What you're looking at is a cadaveric dissection where they have retracted one side of the hemisphere, and you're looking at the interhemispheric space from the posterior view. And you can appreciate the Falx on the right side. Let me mark this, please. This is the Falx, which is on the right side of my screen. This portion here is the tentorium cerebelli. This is the falcotentorial junction. In fact, let me mark this with blue because straight sinus is running in here. And just under it, you can appreciate the splenium here. Mark it. Is this visible here? This is the splenium, because if you remember, posteriorly, the posterior-most portion of the Falx cerebri had splenium just inferior to it. So we have the splenium here. Once we split it even more, this is only showing the venous anatomy, but if we split it more, we are going to see the pericallosal arteries running on the corpus callosum, and the callosomarginal artery is running just superior to the cingulate gyrus. So this is the space in which we have to enter for our surgical Falcine meningioma. Is the orientation clear? Am I audible?
Yes, audible.
Okay. So the bone has been taken away from the first image, if you can see this dissection. And some portion of the lacuna, which is right around the superior sagittal sinus, this is the superior sagittal sinus. The lacuna is visible here under the dura. Once we open this space, this is the interhemispheric corridor. It looks like there is no space, but if you look closely between these two retractors, this is the interhemispheric corridor. Superior sagittal sinus is visible here. The bridging veins, the main cortical veins, they are also visible here, which are a major concern once we are retracting one portion of the hemisphere. Because if you end up avulsing this vein from here, where it is entering in the superior sagittal sinus, patient is going to end up with a venous infarct, which is not something we want. Apart from that, in this image, you can see the paired structure. Which vessels are these? If the structure underlying structure is marked as corpus callosum, these will be
Callosomarginal.
no. These will be pericallosal arteries. Let me show it to you again, because this is a very congested image. If you still look closely, this area here is corpus callosum. The paired arteries that run right over the superior surface of corpus callosum, they are the pericallosal arteries, which are these. The callosomarginal will be somewhere around here. I'm sure they will be visible in any other image. They have taken away some portion of the venous anatomy and given us a closer view in the third picture. And you can see the Falx. You can also see the cingulate gyrus, which is visible here, and the corpus callosum, on which we have these two vessels. There it is. These are just zoomed images of the previous dissection. There's only one difference. What difference do you think this is? Which portion is this showing? What portion of the corpus callosum or the interhemispheric fissure is visible here?
Interior and middle.
It is mainly middle and posterior. What is this portion here? This will be the splenium, right? Because that's the posterior end of the corpus callosum we can see from the superior portion. So around here, or maybe just underneath it, splenium is going to be there. So the exposure that we have is from the middle or the posterior segment of the Falx. We do not have the anterior exposure. Why did I take an extra minute to mention this? Because the next images that you are going to look at are going to have anterior exposure. This portion is the anterior exposure because the structures are different. Let me start my pointer again. If you ignore this bridging vein here and you take a close look, pericallosal, and we are continuing anteriorly, and the corpus callosum is ending somewhere right here. So probably we have reached the genu. Just underneath it, callosomarginal artery is starting. You can almost see the origin if you zoom in here. Unfortunately, I cannot zoom in here, but the portion here, this is the anterior skull base. So we are looking at anterior to middle exposure of the interhemispheric corridor. Once we open up this space, as much as they have opened up in this image B, you can now see that this is the anterior segment and the genu. And just underneath it, once we open this space more, anterior to genu, we are going to find all these vessels. You can take a look at A3, you can take a look at A2. You will even be able to see the ACA-ACOM complex if you retract this space even more and take this paired structure into the exposure. So it all depends on the exposure you are going to aim for. If you go posteriorly, the exposure is going to look like this. Let me go back. Under the microscope, where you won't be able to access the proximal portion of the ACA, but if you go anteriorly, retract this space, you can access the proximal portion of ACA and the proximal segments along with the ACOM. Am I clear?
Yes.
This is an illustration that makes it slightly easy what I'm trying to convey here. Let's mark. So this portion here is probably going to be middle Falcine meningiomas because we do not have sutures, so we don't know. And once we go anteriorly, this will probably have the anterior Falcine meningiomas. And here you can see how A2 and A3, they climb up along with the corpus callosum. And you can see the ACOM and the ACA complex, which is the anterior exposure, the exposure that you saw in the last few slides. We are only going to do the topographical subtypes of Falcine meningiomas because the anatomy did take a very long time. The topographical types are easy, and they are what the types of parasagittal meningiomas were. The anterior portion starts from crista galli to the coronal suture. The middle portion starts from coronal suture to the lambdoid suture. The posterior portion starts from the lambdoid suture to the torcula. The division of the topographical clinical presentation, it stays the same for the parasagittal meningiomas and for the Falcine meningiomas. The presentation is also more or less same. We are going to discuss presentation in a separate session along with the radiology and the surgery, etc. But more or less it is the same. For anterior meningiomas, which are here, patient will present with frontal lobe syndrome, apathy, abulia, personality changes, memory impairment, etc., etc. For the middle Falcine meningiomas, patient can present variably depending where exactly the lesion is. If the lesion is more towards the paracentral lobule, somewhere around here, then the patient can present with seizures, with neurological deficit, with loss of cortical sensation, If it is slightly anterior, then patient can have the association motor cortex, the supplementary motor cortex area syndrome. Apart from that, the presentation will also depend on if it has involved the superior sagittal sinus or not, or if there are features of venous engorgement or not. The posterior meningiomas here, they present in a similar manner, involving the occipital cortex. So the patient can have visual deficits, often homonymous hemianopia, right? Sometimes visual blurring, sometimes complete loss of vision. Seizures as well, which involve the occipital region and have visual aura. So the presentation is going to be heavily dependent on the exact location of the lesion. Let's come back here. Okay. If you look at this small chart, which has this comparison, anterior third is again, these are large. Why are they large? Because they are silent, the area is huge. We have a lot of space, and patient might have frontal lobe syndrome, but otherwise they present very late. Middle third presentation is similar to the parasagittal meningiomas. They usually present early because the area is way more eloquent than the interior region. Posterior third presentation is closely related to visual cortex. And if there is involvement of torcula, then the management and the presentation could also change, along with the fact that if the Falcine meningioma is towards the site of the dominant transverse sinus. So it will depend heavily on how big the meningioma is and what important venous structures it is involving. So that's it for today. We will continue from Friday, inshallah, Friday and Saturday after Eid. Eid Mubarak, everyone. Please let me know if you have any questions or any feedback.
Thank you.
Okay. Thank you so much, everyone. Leave me questions or feedback if you have any on the group. Have a blessed